Hello, everyone. Thank you very much for the invitation to this impressive conference. My name is Dr. Omar Ayoub, and I'm going to talk about the critically ill. When do we need to act? So the important question is always in clinical work is when, who, how, and why. These are the important questions that I will answer during my presentation. So with regards to the when do we need to think about critical care, or when do we need to think about a patient with acute stroke that can be critically ill? It can be seen at different kinds of strokes, which is the most important of which is acute ischemic stroke. So think about the critically ill after you give TIV TPA. Think about it after you do thrombectomy. Think about the infarct growth and the edema, malignant MCA, hemorrhagic transformation, reperfusion injury. Think about it when you think about the airway protection for those patients, and when the airway can be compromised, the incidence of angioedema and also other cardiac conditions that can be associated in patients with acute stroke. Again, when can you think about critically ill acute stroke patient in hemorrhagic strokes in general, because those patients are prone to edema, high ICP, there is potential herniation. Think about blood pressure management that are important to be managed in a critical condition, subarachnoid, and all types of different hemorrhagic strokes. Glycemic control is important, fever and sepsis, bleeding, and also thromboembolism that can happen. So to ease up the way we approach acute strokes with critical needs, a 65-year-old who is a diabetic and presented with right-sided weakness, and he had decreased sensation to the right side with right cubic field cut, and obviously I'm pointing to large MCA stroke. And upon assessment, you found that this patient has difficulty in breathing and has some tachypnea. So the question is, when do I intubate such a patient? Every comer should be intubated, or there are certain criteria? And to answer that question, there have been multiple papers in the literature that looked at the 1 year survival in acute stroke who required mechanical ventilation, and also the predictors for mechanical ventilation in patients who had acute stroke. So in general, with large multicenter population studies, there is a need in acute stroke to be mechanically ventilated in about 10 to 15% of those patients. There are 3 to 4 more times in patients who are having bleeds, such as subarachnoid or ICH. And the prognosis, usually it's indicative of poor prognosis, also depending on the cause. But overall, if you compare patients who are mechanically ventilated, has hospital mortality between 53 to 57%. And this percentage goes higher if you look at them after 1 year. Then again, the mechanical ventilation is major predictor of mortality in a population-based study of around 800,000 patients. Mechanical ventilation reduced the probability of being discharged from home from 37 to 12%, and it is a surrogate marker for clinical severity. But keep in mind that sometimes we ventilate patients who does not have very severe stroke, but they have other conditions such as aspiration, seizures, PE, and so on and so forth. When they looked at the different predictors of those patients with acute stroke that will require mechanical ventilation, we can see that the stroke type, the reason for intubation, and the GCS at the time of ICU admission will predict their long-term outcome more than anything else. So if you look at the reason for intubation and you compare, if the reason was cardiac arrest, you can see that the survival probability over time decreases significantly in this graph. And compare it to those patients who were not intubated because of cardiac arrest. Let's say if it was an elective procedure to protect their airways, you can see that their survival chance will be much higher than those who had been intubated for cardiac arrest, or if they have acute renal failure at the time of their event. And even when they segregated patients with acute ischemic stroke or ICH or subarachnoid, we can see again that this is replicated, and the reason for intubation plays a major factor into determining the long-term outcome of those patients. And then we come again to the question of Why does it happen? Why patients have decreased protection of their airway? Why do they have problems with their breathing? It depends sometimes on the type of stroke, the location, the volume, the presence of edema, aspiration. There are certain theories that invoke inflammatory changes and local lung pathology. Now we go back to the case. After discussion, you elected to give TPA, and which patient may need ICU admission after IV TPA? And that question was simply looked at with different angles, and they have proposed different scores. This is one of the scores I like, which is the ICAT score. I will come over it in a few minutes, where they looked at the different characteristics of patients. Is there any baseline characteristic that we can predict who will be transferred to the ICU after IV TPA? And pretty much they were all not significantly associated with an increased risk of mechanical ventilation. But if you look at the score, male sex, black race, if there is systolic blood pressure of high blood pressure, or the NH stroke scale, these are the 4 or the 5 different variables that were associated with ICU intubation after IV TPA. So in male sex, if it is yes, then score 1, and the black race will score 1, and systolic blood pressure, it depends on the level, but you score 4 if it is more than 200, and if the NIH is significantly high, you can score 2. So if you cross score of 7, this is the high likelihood of this patient specifically will be intubated. What about if you have given the TPA and then you are called to see him by the nurse and says that there is swelling in their face? And obviously, I'm talking about the oral lingual angioedema after IV thrombolysis. This is one of the situations where you have to really think about whenever you are giving IV TPA. It is not very common, but it occurs if you give thrombolytics all year long. It occurs in about 2.2% in one of the reports, and it can be sometimes higher, usually predicted up within a mean of about 70 minutes. That means an hour after you have given the TPA. Fortunately, in those patients and in this report, like none of them needed intubation, but be prepared to intubate those patients if needed. And these patients who developed the oral lingual edema, they were more likely to be on AC inhibitors. They are more likely to develop symptomatic bleed by the NINS criteria, and they are more likely to be having total insular infarct, and can occur also at the site of the infarct. So whenever you encounter someone who has been on ACE, who had insular infarct, this likelihood of oral lingual edema will increase. If you see the oral lingual edema limited to the lips and an anterior tongue, most likely those patients will maintain their airway and you will not need to intubate them. But if you see it extending beyond, going to the palate, the soft palate or the hard palate hyperpharynx, then this increases the risk of intubation and being mechanically ventilated. Antihistamines, steroids, epinephrine, generally they are ineffective. But you know what? Give it either way, because you'll never know which part of the receptors is invoked in that pathway. We know from physiological data that bradykinin is implicated in the oral lingual edema. That's why the antagonists for bradykinin B2 receptors, such as icatibant or ecallantide, these two can be given to reverse the effect of oral lingual edema. Then we shift gear to we will shift gear to thrombectomy, and what are the reasons to intubate such patients. So we can divide them into 3. Sometimes we intubate them pre-procedure or post-procedure, and sometimes we intubate for blood pressure management. And some of those patients may stay on the ventilation, and we can say that there is prolonged ventilation after thrombectomy if it extends beyond 96 hours. This is one of the papers also I like about the prevalence, predictors, and outcomes of prolonged mechanical ventilation after intervascular therapy. And if you can see that they have looked at a different characteristic if they are associated with prolonged intubation. And if you can see, there may be a hint of diabetes, if the patient has heart failure, and there is a hint that there is of if the patient had a baseline chronic lung disease or pulmonary problem, then they will be more likely to be intubated for more than 92 or 96 hours. Does that affect anything? Yes, it will increase the risk of mortality. It will increase the risk of post-operative shock and so on. So the longer that the patient is on the mechanical ventilation after thrombectomy, the more likely that they have potential harm, either to affect their mortality or their morbidity overall. What about recanalization edema? So theoretically, if you open up an occluded vessel, you are increasing the risk of having recanalization edema. And this paper had looked at the effect of recanalization in patients on cerebral edema in ischemic stroke, if they were treated either with IV thrombolysis or endovascular therapy. And as we can see, that to the contrary, and to prove the concept that recanalization is the most important thing to do, where if you looked at those patients who had been recanalized, they have higher level of no evidence of edema, and they have less edema in comparison to those who are not recanalized. So recanalization decreases the risk of cerebral edema on patients who have been either thrombolized by IV or had been thrombectomized. What about malignant MCA? This is one of the situations that we encounter very frequently in our clinical care, and it is extremely important to think about it, and also to think about what are the predictors that can say which patients will go into a malignant MCA and should be, let's say, intubated early and should be taken to the OR early. So there had been multiple papers looking at the different predictors of development of malignant MCA, and they found that younger age, higher admission of NIH stroke scale, and large parenchymal stroke on CT scan increases the risk of malignant MCA. And again, that risk increase with successful recanalization. This is one of the also scores that I like. If there is effacement, if there is midline shift, according to the degree, if there is impairment of glucose prior to stroke, and if there is any intervention or not. And if you have score of 7 or more, that you have a positive predictive value that this patient will develop malignant MCA. So if you were able to recanalize by giving IV TPA or thrombectomy, then well and good. And if not, then you have to think of an early intervention. Now back to the case, and you got called again. The patient level of consciousness became low. You got to see the brain, and you find that the patient had intracranial bleed. And this is one of the important papers that looked at the treatment and outcome of hemorrhagic transformation after intravenous TPA in patients who had acute ischemic stroke. And the general agreement is that we have different kinds of hemorrhagic transformation, ranging between hemorrhagic transformation or hemorrhagic infarct type 1 and type 2, and parenchymal hematoma type 1 and type 2. If you look at the literature, by the NINS, we have different classification. By the ECAS, we have different, and there is also the Heidelberg classification. I think one of the maybe most agreed classification on hemorrhagic transformation is the ECAS, which personally I use quite a lot in deciding of what to do in patients who had developed bleed after either TPA or after thrombectomy. And the definition of symptomatic ICH also can be quite different between different kinds of studies. But in general, if you had any patient who had clinical deterioration, and the time factor can be within 24 hours, and there is a drop in their NIH stroke scale, and there is evidence by CT scan that those patients developed ICH, then you can define them as symptomatic ICH. What to do with those patients? First, you have to think about a score that predict which patients can develop ICH, and there are different scores that you can use, and you can look at them with different positive or negative predictive values. But what to do with it? You have different plans in patients who are developed, let's say, bleeding after thrombolysis. You can give cryoprecipitate. and there is a potential benefit for all patients who had symptomatic ICH, and antifibrinolytic agent also has a potential benefit. The others, platelets, fresh frozen plasma, and the PCC, vitamin K, the factor activated factor 7, they all have potentials. And if you work in a place where you don't have cryo, or you don't have antifibrinolytic, or you only have FFP, then give what you have. At the end, you want to normalize as much as possible the prolonged bleeding time given by the or incurred by the TPA. But again, the cryoprecipitated and antifibrinolytic probably have a better evidence for treatment of patients who had bleed, and in addition to very good supportive care in the ICU to prevent further expansion by controlling blood pressure, by controlling sugar, and also uh, doing proper ventilation techniques during the ICU stay. By this, I have finished my lecture. I'm really thankful for your presence and for hearing me. And we'll start taking questions during the break time. Thank you very much. And thanks again for the invitation.